Yeah.
So Johannes will give you the case presentation. It's a post-CABG patient, a very nice lady. Okay, Johannes, please.
Hello, everyone. Hopefully everyone is fine. No one is suffering any serious condition like headache. I may introduce you a 78-year-old woman. She's suffering from angina class 2 since a couple of months. She has a normal LV ejection fraction, otherwise pretty healthy. And she has a history of a bypass surgery a couple of years ago with a Lima LAD graft, a venous graft to the RCA, and a free radial graft to the obtuse marginal branch. She was admitted for a angio because of the chest pain. And what we see is a CTO of the mid LAD, occlusion of the obtuse marginal branch, and a severe stenosis of the proximal circumflex. The Lima graft is not really well developed, functionally occluded. The free left radial graft is good, patent, and with a good runoff. The RCA is patent, no severe narrowing here, and you can see the LAD is filling from retrograde. This is the left native system. So to sum this patient up, we have a class 2 angina, normal LV ejection fraction, patent free left radial graft, occlusion of the LAD, and so we're here for complex PCI again. Next slide. We have a JCTO score around 2 points. And now the question again, what is your strategy? Last picture.
Okay, maybe it's good to discuss this within the audience up front.
Probably to help the audience a little bit more is because we were also discussing a lot, but I think the easiest is to show
them
the setup shots. So therefore, I think it's mandatory to make a fair discussion to see the setup shots. So what we can see here, probably just to let you know, we have 2 7 French guides in. What we see here is a very well filling LAD over a not so nice epicardial, tortuous epicardial connection, where we're also discussing about if it's variable or not. It may be, but I can't be 100% sure. So therefore, all the strategy is more and more based on good antegrade wire skills, or I think, but we can have this discussion open. There's a feeling, a retrograde feeling, and we didn't understand initially the antegrade cap. So therefore, we did a little bit more accommodation. And there's also some line left of the artery, and you may think that this is also contrast, but I don't know what it is. But here you can see the retrograde feeling. So the antegrade cap actually is a little bit difficult to understand here for us. So we changed projection, as you can see here, and then we have to say, indeed, this is more than 20 millimeters, because we thought it's a functional occlusion and very easy and fast forward, but it's never easy, especially as post-CABG patient. So I think these are where the setup shots we did. We did a spider view also, but it didn't give us any information here. And so therefore, we can open the discussion.
Yeah. So now you have all the data in your hand and in front of your eyes. So just a question, who will start antegrade here in the room? Okay. So who will start retro? Yeah. So we're just asking the room about our common strategy. And okay, I think we are all agree about starting antegrade, but here the difficult point is to know and to define the proximal cap. So I think it will be your major issue here in this case. We are all agree that the retro seems to be very complex with this epicardial, but the second point is, if antegrade fail, what is your second strategy? So we will turn retro. We will turn ADR.
Yes, this is a very, very good question.
Yeah.
It looks like they switched to ADR after integrate wire skills.
So we have the decision of the room, so now we listen to you. But you don't know the decision of the room.
No.
Okay.
So Alex and I was discussing a lot. I think, first of all, it depends how we fail in antegrade mode. If we are very, very near to the distal cap, then probably sometimes also, to be honest, the parallel wire can be an option. And but the other alternative is, and if we decide for that, for an ADR or Stingray, would be that we convert not too late. So the very important thing is not to create too much hematoma on the distal cap. So therefore, even when I will go with the wire towards the distal cap, you will probably see that I give a lot of contrast multiple times. The renal function is good to really be sure in front of the cap that I really make a good puncture. And this is crucial. I hope that I can avoid to hematoma, because this is diffuse disease, and if you create hematoma, the filling will be completely done probably for the first 20 to 30 millimeters.
Yeah, because it's already kind of compressed, as you see there. It's
Exactly.
disease there.
Exactly.
So furthermore, it's at the bifurcation. So if we plan to do an ADR, we have to ask ourselves: Are we going to lose, or probably going to lose, the diag, and is it the territory is small enough to do so? So that's another question. When you have you're going to lose it, but will you sacrifice it? That's another question when you do
unless
ADR
you succeed to
and it
to
doesn't
penetrate.
look that yeah, unless you're able to penetrate, of course. But
so what we already did is not a lot, because we stopped. We really wanted to wait for you for educational purpose. We tried to bring a wire in that was the Field XT wire, and I'm happy because it showed me at least a cap, which we didn't understand by angio, and we couldn't make an IVUS. But there was the wire end up somewhere with a lot of resistance, which means that should be the cap. And because there is so much resistance, I tried to rotate the wire through this resistance. I stepped up.
you see here that the combo is coming back, or the teleport catheter is coming back here.
Yeah.
There's a lot of friction, there's a lot of resistance into this cap.
So therefore I stepped up to the next wire, which is a Gaia third. And with the Gaia third, at least I could penetrate here the cap. And now it's getting interesting. How will this wire behave? We are at this position here, and already the wire is a little bit deviating towards the left. And this is where we are. So we are live now. And Alex, could you give us a retrograde shot? Okay, go.
Yeah.
Which micro?
It's teleport.
Which one?
See?
Which one from?
The control.
The control.
So we are definitely in the vessel architecture. I try to advance a little bit my.
You can see that it's aligned and it dances with the calcium. So therefore, we're pretty sure we're in architecture.
Now, what we did not discuss
slowly
yet, Kamis, there's an occluded bypass anastomosis on the way. There's an occluded lima anastomosis. And I think this has an implication for any technique, either subintimal technique or direct passage with a wire. And so it's calcium, it's a blunt occlusion, it's calcium is more than 2 centimeters, and it's a bypass anastomosis. So this is not included in the Swiss CTO score, but it's at least 3, or should be more 4 than 3. So it's a really very complex lesion. And the bypass anastomosis distorts the vessel a little bit. It was shown very nicely yesterday in a talk, and so maybe the vessel course is like this and not straight, and this is all very difficult.
And you're right, Hakim, as you said, post-bypass patients are an independent factor of failure. So maybe it's occluded at the point of the anastomosis, we don't know.
But we're still making progress. It's following the calcium, it's in phase with the calcium, so far so good. It's very important not to buckle the wire. Campus is very gently maneuvering the wire in an antegrade fashion there.
And what is your Cambis? What is your tactile feedback here? Is it hard?
There is a lot of resistance. Can you see the microcatheter going back when I want to bring the wire forward?
So maybe.
You can
So
screw in the proximal cap.
Yeah.
Nice maneuver.
You got enough grip in the lesion to get it in probably.
But I think this may be uncrossable for the MC.
For this MC, yeah.
No, it
you
works.
can see the torque
okay,
on the MC.
Can we see his hands, please, with the camera?
The wire is backing out, so we have to take control of that.
Wire is coming back again.
Wire is coming back, yes. So we heard kind of algorithms yesterday already about when the wire goes, but the gear doesn't.
Can you give me a check?
Several options. You want an injection?
Yeah, please. Okay. So
there is somebody in the room shouting at us. Another one?
Yes, please.
Yeah.
Go. So we are not dead here. We have also some support from Sicily, screaming around, ready.
Can you advance the MC, Gambis? Because I think that would have been of help also for the steering. The steering properties of the wire at the tip would be better if we advance
Can
the
you give
MC
contrast, please? Yes, I will do.
But the way out at the distal cap is also a key point.
Subintimal.
It's subintimal, yeah.
It's very important because this is now the most interesting point, is how to cross here.
Any thoughts for the audience who would proceed this way, who would do something else? The same wire, other wire?
Hi, Alex. This is Paul.
Hi, Paul.
Hi, Columbus. Well, I just wanted to say that even though the landing zone looks pretty fragile, one of the advantages of post-bypass patients is it's severely calcified, and the hematoma formation is often much less in these patients. So I think, obviously Columbus is very experienced with wiring, and he should definitely give it a go, as he's now doing, to retract and redirect. It's sort of a virtual parallel wire technique, which is using now. But that landing zone is beautiful. It's absolutely beautiful. So I would say, okay, spend another 15 minutes or so on wiring, but actually you're already without a crossbus. You're already adjacent to the vessel, already almost in a good position to drop a Stingray balloon there.
Well, that's what we discussed also already. So we're going to try and give it a few more minutes, but if not, we're probably going to convert to an ADR technique. There's even more support from Sicily.
Just check, please. Is this right?
No. That's a septal?
Yeah, it's a septal.
That's a septal. So we're going to confirm from another angle that this is a septal. Okay,
go. Yeah. This is exactly.
It's under it.
Yeah.
It's not a septum. Subintimal.
I'm not sure.
You see there. You're already under the landing zone.
Are you able to move forward your microcat, or are you stuck here?
No, I'm a little bit stuck.
For the audience, the advantage of the Gaia wires family is to be able to be talkable at a long distance from the tip of your microcat. It's not the case for the tapered polymeric jacket wires, and the Gaia wires are very effective in that case.
See, Camus is trying now to get it in, but the wire is coming back. You see the guide. Yeah. The guide is coming out.
Kannst du mir ein bisschen mehr aufmachen seitlich, bitte?
So it's very difficult at this point to get this MC into subintimal plane now. So we have to think of the next step.
Okay, who in the room think that he will cross-integrate with the wire? So you have to insist a little bit more.
So now I have no.
So you have some
feeling.
supporter in the room.
Okay, can we have a trapping balloon and a Sapphire 1-0?
But why you think this? Because you don't know how to use Stingray, or because you are sure that you will go inside the true lumen with the wire? So I'm asking the guys who are just ending the end. So
The occlusion length is short.
So
No.
I show you because you're first in front of me. So why?
No, so I think ADR is a strategy to go now. That's what I would do. Okay. The only issue is crossing the Stingray through the calcified part.
I think it will be great.
So what we're going to do now, as you may have seen, that we're going to trap out the MC. I'm going to use a Sapphire 1.0 balloon from OrbusNeich, which is a very good balloon in CTOs. It's very slim, very slippery, so it usually passes tight lesions to make some room, and afterwards we're going to retry to get the MC past this point.
I just crossed, Alex.
Perfect.
Another retro injection, please. Retro injection. And move the wire. Yeah, we're in.
Yeah, great.
Yeah.
You don't have any support of microcat, huh? Cambis.
No.
Okay, up.
Funny.
So
some bad songs are saying that it went by mistake, but it's not a mistake.
I don't.
No,
maybe
no.
I don't know, but okay, trap.
this means re-entry on the way back.
It's the colleague of
sometimes
Alex
it
who say
happens.
that. The
What should
colleague
we
of
do?
Alex who say that.
Yeah. Well, at least it.
It's in.
At least it happened. Okay, now the Sapphire, and
So we're gonna dilate it now with the Sapphire.
Okay. So
And
now
then,
I
bring in.
we just switch to the other room.
Yeah, that's fine. After we had managed to get the guy at 3 true lumen. Okay, so we dilated with the 1.0 balloon, and then we exchanged for regular wire, and we optimized the LAD. Put a 2.5 stent more distal.
oh, now you can see it.
You can see it, and a 3.5 stent
It was the
proximal to it.
The wrong one. Okay, next image, please.
And we post-dilated the whole LAD, and the result is beautiful.
Just the last result, please. That would be so great for the people. I mean, we know that it's okay. Yeah.
This one.
Okay. So the circ was stented, the LED was stented, and I think it's okay. Yeah. Thank you very much.
Thank you.
Yeah, very nice outcome.
Okay,
Yeah,
see
very
you.
much impressive. Thank you very much.
Thank you so much.